Thank you very much. I've heard that, and I've heard the comments about David Warrell, which he remains an inspiration to all of us down here in Nigeria. I wonder whether you're seeing my slides now.
We do, yes.
Okay, so basically my presentation is on establishing a network of snakebite sites in the tropics in Nigeria in particular, and also the clinical audit of the 20 minutes whole blood clotting test and the implications of its use as regards antivenom therapy and outcome within routine care in northern Nigeria. This work was done by many colleagues who I will acknowledge is not only me at the end of the presentation. And the outline of the presentation basically takes the form of these networks of sites, about 4 sites which were established, and also the use of 20-minute whole blood clotting test in routine clinical care in resource-constrained settings, especially in the context of Nigeria, and the performance of the test as a snakebite envenoming detection test, and also its performance in monitoring of carpet viper envenoming and the relationship of the test to outcome following snakebite envenoming. So basically, looking at the literature, we realized there are a number of databases for snakebite, but most of them really are within industrialized countries. I know in the United States, they have a large database through reporting, and often researchers go back to explore and probe the database to answer clinical questions. And also, I think in Brazil also, I've seen the SINA database, but in most instances, this is through retrospective studies rather than on questions that are prospectively conducted. So working with our collaborators within the Liverpool School for Tropical Medicine, the question came up that we should try and establish potential clinical trial sites in case antivenoms, new antivenoms are made available, or new agents and small molecules are made available. So the original conception really was partly from Liverpool for the purposes of clinical trial sites for antivenoms and other products in the future. But along the line, even after the completion of our work with Liverpool, we thought perhaps we should maintain these sites for other studies, beginning clinical characterization of snakebite, especially in the context of new species or characterizing equi-species, the Romana, the Equus oscillatus, the Lycogaster in Nigeria. We thought perhaps with such a network of sites, we may be able to explore that. Secondly, further characterization of the epidemiology of snakebite, especially we got interested in geospatial patterns and GIS studies, which lately has been gaining momentum. And thirdly, we thought also implementation science and operational research to resolve important clinical implementation, clinical and public health questions in the context of routine care. And then lastly, also it will allow us to look at long-term effects on snakebite patients, especially they will be able to get the patient's names, addresses, phone numbers, and potentially also the geo coordinates of where they were bitten or the closest village where they come from. And we thought also in today's world, availability of big data will be very useful in the future. So with these objectives in mind, we maintained these sites, beginning with 4 sites which we call health facilities managing snakebite in the country, beginning with Kaltungo and Al-Kaleri in Bauchi State, Zamko in Southern Plateau, and also Lokoja at the confluence of River Benue and River Niger. So these 4 sites are part of what the Federal Ministry of Health has been using to treat snakebite through providing antivenoms. And in the course of 1 year, we started January to December 2021, although we had meetings with investigators, advocacy calls to these sites, medical doctors, nurses at these sites. Sometimes in December 2020, we developed a pro forma, which they all contributed to. And then eventually, through the 12 months period, were able to collect fairly detailed information on victims they managed. And as you could see in Kaltungo, in the year, they had 2,381. In Al-Kaleri, they had about 103. In Plateau, Zamko State, they had about 449. And Lokoja, which is actually the capital, is a cosmopolitan city. I think I'm told John Major at some point was a bank manager in Lokoja. They had 9 cases only. Totaling, we had 2,942, and you could see the disposition of the patients in these sites. In Al-Kaleri, patients had a median delay of 12 hours. Zamko, they had median delay of 4 hours. The Lokoja, they had median delay of 12 hours, while Kaltungo had the longest. By way of mortality, the Zamko and Kaltungo that have experience in managing snakebite had about 1.4 and 1.8% case fatality rate, while Lokoja had, with 9 patients, only 1 died, given about 16.7. And also we looked at the patient demographics, the age, the gender, and the distances they took to arrive at these locations. Between them, these 4 sites manage over 50–60% of snake bites in Nigeria. Before COVID, they on average will have about 8–9,000 patients. Post-COVID, there has been decline since 2020. So, and then we characterize the patients from the states, different states, they arrived at these 4 locations. You could see, although Kaltungo in Gombe managed 2,300 from the previous slide, but the number of patients from within Gombe State actually was 1,200, something that the governor in Gombe State always says, that he's managing snakebite patients for the whole country. He's not only managing for Gombe State patients. And you could see Taraba that has about 380. This is where Sir David Warrell started his career. Plateau has around 400. Adamawa has 300. Borno has 100. And the Kano, Katsina, Jigawa had 1 each. And then Nasarawa State about 25 through the year. Recall all of them actually accessed care from those 4 sites. And we did some analysis of the distances they covered. You could see that about 14.8 took 2 hours to arrive at one of these 4 sites. And recalling that the World Health Organization has a definition that an individual should have access to emergency care within 2 hours. So meaning about 85% of our patients fail to meet this WHO target. Similarly, the distances covered about 20, just about 15% got care within a distance of 20 kilometers. And we zeroed to see how many local governments contributed this nearly 3,000 patients that we saw. And we found 94 of the 770 plus local governments in the country. And the one local government that had the highest was Karim Lamido, Again, I think this is where Sir David Worrell started work at Bamboo. And we mapped the primary health facilities and the geolocation of the patients who were bitten, who come from those locations, as you could see them here in yellow bolts. We had from Karim Lamid 267 cases in 2021 on a population of 260,000, given a hospital incidence of 103 per 100,000 population. Recall, this is not a population study, but still it's a remarkable figure. And then we said, let's explore the distances they covered. So we got a map of the same local government, and this time around fitted the secondary health facility there. You could see the Bamboo General Hospital, and we placed a buffer of 10 kilometers and 20 kilometers. And we're able to show that, surprisingly, about 40%, 50% of the patients are still within this buffer of 20 kilometers. However, that particular secondary facility does not have antivenom. So in other words, they still have to cross this particular secondary facility to go to Kaltungo or to go to Zamco to access antivenom. And as an advocacy, we thought at least secondary facilities within these local governments should be able to administer antivenom, so to say. And then we said, okay, if we look at tertiary facilities within where these hospitals come, because we realize for neurotoxic snakes, which fortunately is not a major problem, availability of mechanical ventilators may be only within tertiary and teaching hospitals. So we mapped all the tertiary hospitals within these states and also placed a buffer of 20-kilometer radius, 40-kilometer radius. And we found that really a significant proportion may still be within 20 kilometers or within 40 kilometers of the total number of 2,940, and potentially, therefore, providing antivenoms in these hospitals, i.e. outside the original 4 sites, will be very useful in expanding access to snake bite care. And then we looked at the profile of patients. As I said, a total was 3,015, 73 were excluded. Eventually, those who had the 20-minute whole blood clotting test at the time of submitting this abstract, the one we curated, were 1,541 of these 2,942. And the 3 sites, Kaltungo accounted for about 1,000 or 65%, Zamco 29%, Al-Galeri 6%. 20-minute whole blood clotting test was not done at the 4th site with 9 patients. Recall, I told you, is a state capital, so perhaps they are not as skilled with it, or that they prefer to do PT, PTT, INR without recourse to 20-minute whole blood clotting test. And when we looked at the major clinical presentations of patients from all the sites, we found about 94% had swelling, about 92% had pains, about 82% had non-clotting blood using the 20-minute whole blood clotting test, and bleeding, either local or systemic bleeding, in about 10%, pallor about 6%, shock 2%, altered consciousness was in around 1.8%, and blisters 1.6%, and neurotoxic presentation was very rare. Only 2 patients had neurotoxic presentation of 0.07%, and other myriad of presentations mostly related to these major ones. And the 81% in coagulable blood all were detected with 20-minute whole blood clotting test, which, to recall, entails collecting 2 to 3 mils of venous blood in a glass, leaving it undisturbed for 20 minutes, tipping it at the end of these 20 minutes. And if blood runs out, meaning there is consumptive coagulopathy or incoagulable blood, And if there is doubt, one may use a control. And potentially, this test can be repeated 6 hours after antivenom treatment until permanent restoration is achieved. This test was started by Sir David Worrell in the 70s in northern Nigeria, and subsequently in different parts of the world, in Latin America, in South Asia. And it remains the one important test that we do within our snake bite units within rural areas that are really resource constrained. So our patients, as I mentioned, we had 1,541 that had 20-minute whole blood clotting test at the time of abstract submission, and also they had antivenom therapy. And when we categorized it into those with antivenom, we found 1,300 received antivenoms at admission, while 238 were not given antivenom at time 0. And in 3 of these patients, it wasn't very clear whether they received antivenom. And subsequently, when we analyzed the relationship of antivenom therapy based on the 20-minute whole blood clotting test, clearly there is a strong relationship of administering antivenom therapy from the chi-square, from the 2x2 table. About 80% with non-clotting blood went on to receive antivenom, while you could also see about 1.8% had non-clotting blood, and yet they were not given antivenom at time 0 for a myriad of reasons. This data, we had excluded other snakes that were brought. The cobra, there were 13, puff adder were 15, and other snakes totaling around, I think 46, sorry, I'm not seeing the final. And then when we broke it down, you see that the 650 of the 1,228 with non-clotting blood also brought the killed carpet viper along with them. And among those who were not treated with antivenom, 238 were not treated, 210 had clotting blood, leaving us with about 28, as mentioned earlier, who had non-clotting blood, and yet they were not administered antivenom. Among these 28, 15 had brought carpet viper, suggesting clearly there may be a system failure, availability of antivenoms, or the turnaround time for patients to go and procure the antivenom, among other things. And sadly, 4 of these 28 patients died before antivenom administration, usually due to stock out or inability to procure, or late arrival when patients present moribund. And usually these 28 would go on to receive antivenom at later periods as families dispose of livelihoods to procure the antivenom. And we said, okay, let's explore. I know many studies have explored comparing 20-minute whole blood clotting test to INR or other clotology, laboratory clotology markers. But then we said, given we are operating within a resource-constrained settings, let's look at the commonest major presentations of swelling, pains, and 20-minute whole blood clotting test incoagulability. All of these were present in over 80%. If indeed swelling and pains were common in over 92% of the patients. So we use the definition of clinical envenoming as concomitant swelling and pains, and tried to compare 20-minute whole blood clotting test to clinically defined envenoming. And given that we had excluded other snakes, we were left with 1,400 patients in who all these 3 parameters were known. So we defined true positives as those who had swelling, who had pains, and had non-clotting blood. And then we had those who have false positive, those who did not have clinically defined envenoming, i.e. no swelling, no pains, and they had non-clotting blood. And then false negative, those with swelling, with pains, and clotting, is false negative. And then lastly, true negatives, those without swelling, without pains, without abnormal clotting, i.e. with normal clotting, so to say. And the numbers are provided in the cell, and we computed, therefore, the sensitivity, i.e. true positives, out of true positives plus false negatives, which came to 85% sensitive, with a 95% confidence limit of 83 to 86.5%. And then specificity was lower. We got true negatives out of true negatives over false positives. This time around, it came to 64% with a 95% confidence limit of 50 to 77%. And then we compared to other studies in the literature, some of which we reviewed last year. We could see in Thailand, 86% sensitivity, 96% specificity, or if you use a threshold of fibrinogen less than 1.7 grams, it fell to 50, 98. Jeffis Vista in Sri Lanka, he had a 40 in 2013 with a specificity of 100. Later, we saw David Williams' study from Papua New Guinea with 93 compared to fibrinogen of less than 0.5 to 91% specificity, among others. And then similarly, we saw Thomas Lamb's study, which also was published the same year, wherein he conducted a meta-analysis where he found the pooled sensitivity was around 84%, very similar to what we got, and the specificity of about 88 or so, 91% in his own meta-analysis. So next we said, let's also explore whether our decisions, how bad our decisions are. We came and said, okay, let's see the ones who are given antivenom and those not given antivenom. So we have the first row, they had clotting blood and they had no clinical envenoming as defined, i.e. no swelling, no pains, and they had a clotting blood, and yet they were given antivenom, meaning this is two patients had this profile, and that is 0.2%. So this is potentially wrong decision. They had no clinically defined envenoming, and also they had a clotting blood. And then we also saw those where the decision was potentially right. They had no swelling, they had no pains, and they had no clotting blood, and they were denied antivenom, 34 or 2.8%. And then in the second row, we had those who had non-clotting blood. The first column, they were given antivenom because they had swelling, they had pains, they had non-clotting blood. That was a right decision, about 95%. And then we also saw those where they were not given antivenom, even though they had non-clotting blood and they had swelling and pains, which was a wrong decision. And so we explored in what proportion are decisions potentially right using just bare 20-minute whole blood clotting tests and also clinical envenoming. Recall, we have excluded data from non-carpet viper snakes. However, there may be some which we did not know because all of these patients brought killed snakes. So we found 97.9% had correct decision. 2 patients, potentially there was misuse of antivenom, 0.717%. And there were 23 out of the initial 28 I mentioned with swelling and pains and non-clotting blood given, not given antivenom. Clearly that was a wrong denial, a wrong decision. And then we went on to explore those who were given the antivenom and how to monitor, to use 20-minute clotting blood to see over time. Originally at time 0, 1300, 5.5% had clotting. At 6 hours, 60.2%, 12 hours, nearly 80%, 24 hours, and so on and so forth to day 4. Of course, the numbers will be declining because the length of hospital stay varies. Some also are discharged against medical advice. They just simply, when they recover, they take their luggage and belongings and leave. And then we also looked at those with antivenom were not given. Initially, 88% with the 28 that were not given. And then as time goes on, you could see the proportion who had clotting blood rising. And when you look at this graphically, you could see that the 1,300 who had non-clotting blood at the beginning had only about 5% clotting. And as antivenom was given, you could see over time it's approaching 100% with the proportion clotting. And you could see the 238 where antivenom was not given. Initially, we said about 210 out of the 238 all had clotting blood. It was about 88%. And then subsequently, as time goes on, you could see that even though they were not given antivenom, it's becoming more perfect, nearly 99 to 100%, so to say. And then we explored from Thomas Lamb's study, although the monitoring of 20-minute whole blood he used was rather a shorter period, 6 hours, 12 hours, 12 hours, but the sensitivities and specificities tended to be lower, 42, 67, 5% sensitivity as you use 20-minute whole blood clotting test with different references, either INH or fibrinogen level. And then we came and explored outcome. We found that out of this 294, 2,940, 89 survived, 23 had complications, 0.8, 47 died. However, 246 were mostly discharged against medical advice. That is to say, they decided they've improved, they don't have the money to remain in the hospital. And among those with the 20-minute whole blood clotting test included in the analysis, 90% were cured, 15% had complications, 20 of these 47 died, while the 113 also were discharged or simply left the hospital when they recovered. And we explored relationship with outcome, the proportion of cured among those with 20-minute whole blood clotting test clotting versus non-clotting. There was similar, if you could see, i.e. the proportion who were cured 99 versus 97. And similarly, when we use trend analysis, i.e. clotting versus non-clotting, compared to either cured with complication or died, similarly, there was really no much significance. Recall, we have excluded where the outcome is unknown in all of this sub-analysis. Again, we looked at the proportion of non-clotting among survivors compared to among those who died, was 81 and 85, no much difference. However, among those with non-clotting blood at T0, antivenom was administered in a higher proportion, clearly meaning it was a wrong decision in those 13 of the 17 who were not given antivenom, i.e. among the 17 or so that were not given antivenom, even though they had non-clotting blood, the p-value is substantially significant. And then we compared the 20-minute whole blood clotting test to snakebite severity score. Initially, the local site of bite with the same gradings of 4. There is strong association by Pearson's chi-square and also chi-square for trend. You could see that many had, a few had minimal or mild lesions, but as the non-clotting blood is going to 2 or 3 mild, 2 or moderate, the proportion sort of is rising. The snakebite scoring test for local is not as used in the literature, but you see it here and there. But for systemic features, we found strong association both by Pearson's chi-square and chi-square for trend, but we did not find a relationship between clotting versus non-clotting for those with pyrexia, i.e. with systemic inflammatory response syndrome. It was 0.27 p-value. And we also found a relationship with anemia, which was only PCV could only be done in 582 patients. The PCV was higher in those with clotting, 19.1, and 17.9 in those without clotting. And the proportion who went on to have blood transfusion also was higher in those with non-clotting, 257 of 1,200 compared to 14 only, and this was clearly significant. So overall, as I finish, the network of health facilities managing sites, snake bites, promised to provide an avenue to systematically study the problem of snakebite to inform practice and policy. The 20-minute whole blood clotting test positivity is almost always due to carpet viper envenoming. However, cases of Dyspholytis typhus and other snake envenomings may affect some of our interpretations, perhaps, and also increasingly the reports of puff adder also causing incoagulable blood. Non-clotting blood was associated with severe envenoming, and withholding antivenom for those with non-clotting blood was clearly associated with poor outcome. And the test still performed very well compared to clinically defined envenoming. And overall, we think the test is very useful in detecting, monitoring, and managing snakebite envenoming in resource-constrained settings where alternatives are unavailable. There are many investigators, colleagues in this, the GIS group from eHealth Africa, from Center for Dryland Agriculture, from Nigeria Space Agency, and also doctors at these locations, Zamko, Plateau State, Bala, Suleiman, Awal, Hamza, Garba. These are some of who are in the audience virtually, and also our colleagues from the African Snakebite Research Group, Rob Harrison, David Laluni, Casewell, and others, and also from the VASP. And as I said initially, the whole work was stimulated following our collaboration with the Liverpool School for Tropical Medicine. Thank you very much. Thank you for listening.
So thank you very much, Professor Habib. That was crystal clear here in the room. You'll be pleased to hear. And I think in the interest of time, we're going to move on to the first session of this conference.